Hi everyone, my name is Dr. Harris Khan, and today I'll be presenting an audit I did at University Hospital Limerick looking at perioperative hypothermia. So, perioperative hypothermia is where the core body temperature falls below 36 degrees Celsius during a period of operation. It's quite common among theaters and carries real clinical consequences. So, the triphasic pattern of heat loss that occurs is the fact that number one is redistribution. This occurs immediately after induction of anesthesia due to vasodilation, which causes warm and cold blood to mix. The linear phase occurs 30 minutes after induction, where the steady heat loss exceeds the metabolic heat production, and ultimately a plateau phase then occurs during the rest of the surgery, where the heat loss and production ultimately reach equilibrium. So the clinical risks of hypothermia include surgical site infections, altered drug metabolism, increased bleeding and shivering, and prolonged recovery time. So our audit aimed to look at the control, monitoring, and documentation practice in UHL theaters against the AAGBI guidance. We did a 3-week cross-sectional audit. All theaters at UHL were included, all ages and surgical types were included. Took randomly 50 patients from the recovery room, which included 21 females and 29 males. And out of the 50 patients or the 50 cases, 12% were pediatric, 50% were emergency, and 14% were cases lasting less than 30 minutes. And 43 of the cases happened to be GAs. Our findings were quite substantial. 80% of the cases did not have a pre-op temperature record checked. We did not know their baseline. 18% had it only 18% essentially had their temperature checked intraoperatively, and 92% had their temperature checked post-op. 50% of the patients were hypothermic by the time they got to the recovery room, and out of the 7 cases lasting less than 30 minutes, only 1 had their temperature recorded, and the warming devices used included warm air blankets, fluid warmers, and sometimes even both. So why does it matter? So half the patients were ultimately hypothermic by the time they got to the recovery room, while monitoring focused mainly on post-op rather than pre or intra-op. And hypothermia once again increases chances of all the side effects of surgical site infections, altered drug metabolism, and bleeding and shivering. And UHL theaters are non-compliant with the AAGBI guidelines. The guidelines state the fact that the minimum standards of monitoring, regardless of duration or location of anesthesia, includes temperature monitoring before anesthesia and every 30 minutes until the end of surgery. So our recommendation is to address the lack of equipment for short-term and short-case temperature monitoring, encourage pre-op temperature check, and emphasis on intra-op documentation as well. So the take-home message essentially is the fact that perioperative hypothermia is common, as shown by the fact that half of the patients audited were hypothermic, and UHL theaters were currently falling short of the AAGBI standards. Better equipment, preoperative check, and documentation can close that gap. I hope you got something out of this. Thank you very much.